Hey, welcome everybody. It is Health Talk, and it's good to be back in the saddle once again. Our friend John King over there. Good morning, John.
Hey, good morning, Peter.
You're welcome back, sir.
Yeah, it's a blast to be here, kind of.
Okay. Fine.
After a week of vacation, it is a little hard to get back in the role.
So you actually wanted to stay on vacation.
Having a chance to float the river every day is not the worst situation in the world in this 100-degree temperatures.
So I guess that makes me kind of a freak.
A fuddy-duddy.
Because I hate it every day. I was just thinking that there's so much going on that people need to know about it. And, so anyway.
Well, that's why we love you.
Yeah. That's why we laugh constantly at you, Peter. Anyway, but we're not here to talk about that. We're here to talk with Apyle Pickering, who is, okay, let me see if I can get this right, the Director of Population Health and Government Programs for Community Medical Center. Whew. How are you?
I'm great.
Okay, well, welcome to the show.
Thank you. I'm happy to be here.
So tell us about Apyle. Where'd you come from? Are you a Missoula gal, or have you been here the whole time? What's the deal?
Well, I'm originally from Vermont.
You're only a hop, skip, and a jump away, right?
Yes.
I was wondering how in the world you ended up in Montana.
Graduate school, actually. I moved to Montana in 2002 and then started my master's degree in anthropology at the university.
So what is population health?
So really it's a very patient-centered approach to healthcare where we, instead of looking at office visits and providing health care to whoever walks in the door, it's more looking at your entire patient population. So that includes everything from office visits to care management to going out to their homes, things like that. So really we look at our population as community medical center and focus on increasing quality outcomes and patient experience.
So are you in charge of running surveys, or do you have the little questionnaire at the door, or do you call people up randomly? Hey, I just have 2 questions. Please don't hang up on me immediately.
My role is actually program director for a lot of the new reimbursement models for how we're paid. So there's lots of exciting things going on in the world of healthcare reimbursement.
How much of this does it have to do with what they call the medical home model? Is it pretty similar or what?
It has a lot to do with the medical home model. A lot of the new payment programs are based on the medical home model and the functions of the medical home model and how you provide care in a more patient-centered way.
I have no idea what the medical home model is. So, Peter's looking into medical homes probably at his age, but I'm at a total loss.
Wow. So every day I get this, okay? But if you look at his hair, you'll see plenty.
I got a lot of sun. Okay?
He didn't just paint. He didn't just paint the ceiling the other day, okay? So anyway, so
Peter
now
asked me if my hair was frosted this morning.
The medical home model is kind of a new way of just looking at the whole picture. Is that right? Where, as you had mentioned, it isn't just going in for an office visit or going to the hospital to get your gallbladder done or whatever. It's from start to finish making sure that everything is looked after, so the patient is first, in each of these events. Is that right?
Yes. So really the center, the hub of your healthcare is your primary care provider or your physician or nurse practitioner that you see. And then they have a whole care team, a team of people that really help you transition in and out of the hospital or a nursing home if you happen to go into a nursing home, or if you had to come in for an office visit. We follow your chronic conditions and measure your quality outcomes.
Does some of that actually include, now this has actually happened to me, people, because I broke my wrist a couple of years ago and I was on pain meds and that, so they would call me every now and then and say, hey, do you need a refill of such and such and so? And I said, no, I sold those already. No, just kidding. No, just seriously. But that was kind of surprising. I wasn't expecting that.
Yes, so it's more touches to the patient, especially if you have an injury or just coming out of the hospital. We really want to follow up with a phone call, and if you're high risk, assign you a care manager. That can be your point of contact if you have any questions, things like that.
Gotcha. So you said you were looking into alternative payment models. And I think I made a joke before the show, like, well, can I do the dishes to pay off my health insurance? But what sort of payment models are available now at Community that people might think of as new or different?
So it's more how the insurance companies and CMS, the Center for Medicare and Medicaid, pays us as healthcare providers. So we still get paid traditionally fee-for-service is what they call it, based on the office visit. You get a certain contractual amount from the insurance company. But there's a huge shift towards what they call value-based payment. So a lot of payment is now we get a certain amount per beneficiary or per patient that we have on that insurance plan, so that we can provide care management and other services. And then we get quality incentives based on how our performance on quality outcomes.
But how do they check you? I mean, how do they check the value of the service you offered? So in the original model, Peter goes in, gets his hand fixed after putting it into a snow machine, and then he pays for the surgeries to get his hand back to normal, right?
Mm-hmm.
Fee for service.
Yep.
But in the new model, then Peter is asked how well he likes his new hand, and if he likes it a lot, you guys get paid more, or what?
So in a new model, like one of the programs we're in is Comprehensive Primary Care Plus. So in that new model, we would get a certain amount of money for Peter every month that we could use for care management, so that we could call him and provide services.
Even if there wasn't a
Even
hand
if
that
he
was
doesn't
hurt.
come in the office.
Okay.
Yes.
Wow.
And then we have to measure about 23 quality measures on Peter.
But could you kind of, if you wouldn't mind, just ticking off a few of those about what the things you're looking for?
23 qualities of Peter. Let's go.
Well, that won't take very long. But go ahead. Go ahead.
Of course, they wouldn't all apply to Peter. But,
One, old.
like, have you had your colonoscopy?
Really, really old. Go ahead. I'm sorry. Yeah.
Have you had your colonoscopy? If you're a diabetic, do you have foot exam, eye exam? Is your hemoglobin A1C controlled or not? How's your blood pressure? So those are all quality outcomes that we're measured on.
So with that system, the idea basically would be that the hospital is now kind of responsible for trying to make sure Peter understands the risk factors of all these different things.
Right.
So, for example, you might be more inclined to say, have you had your colonoscopy yet? Or whatever the case might be, to try to get Peter to make sure he's taking care of himself.
Right. We're paid to keep Peter healthy, as opposed to just getting paid when he's ill or needs to come in the office.
Now, let me ask you this. Do you find patients do they enjoy getting these calls, or do some people say, why are you guys calling me? I'm fine now. I got the deal, got my service done, I paid the bill, I'm done. Or do you find any resistance from folks?
So we don't really call patients unless they're transitioning out of the hospital to the emergency department.
Okay.
Or if they're in our high-risk population, so we risk stratify based on utilization, how many times they're in and out of the hospital and how many chronic conditions they have. So those patients would be assigned a care manager, so they would get called and get familiar with that person. They actually receive it very well, because often they have a lot of questions and they need services set up once they're discharged from the
So rather than me trying to get on the phone and not being able to get a hold of someone, you guys actually are proactive and call us.
Correct.
Wow.
So I guess my biggest question as someone that's buying the service in a different way would be, well, how do I know I'm not paying you for stuff you're not doing, right? If I'm not doing just a fee-for-service model, how do I know that you're not just taking the money and not using it?
As a patient?
Yeah,
or,
as a patient, sure. Or as an insurance company, or I guess I'm kind of the end result of both, right?
I guess he's asking is, how do you verify all this?
Yeah, so it's a lot of this is now publicly reported. So anybody can log on to Physician Compare if you have Medicare, and you can see all the organizations and providers are rated. We've been reporting quality measures to the government or CMS for years, and now that's public, so you can sort of look and see, how is my provider performing on quality outcomes, or are they communicating with me no matter who I see, if I see a specialist, those kinds of things.
So this alternative payment model is only through Medicare?
So Comprehensive Primary Care Plus which is one of the alternative payment models. There's a lot of them out there.
So comprehensive care, the original was kind of undersold because this one's better. It's got a plus
Yes,
on it.
it's a plus this time. It was just comprehensive primary
Not as
care.
comprehensive as you
Now it's plus.
Now it's incredibly comprehensive.
double plus
So
comprehensive.
we're up against a break. We have all 4 lines open. If you'd like to visit with Apyle Pickering, she's the Director of Population Health and Government Programs. So you have a question about this, what we're talking about today. 721-1290 is our number, 1-800-568-5309. You can also make your comment on our Facebook page. We'll be happy to pass that along to Apyle, and we'll be right back with more of Health Talk in a moment. Hey, thanks for joining us here on Health Talk. 721-1290 is our number. And we have Dave on the line. Wants to visit with Apyle Pickering. Dave, good morning. You're on Health Talk. Go ahead, sir.
Yeah, good morning. I was wondering what community center has to say about the House of Representatives health care plan. The Senate doesn't have a plan really yet, but I was curious what's your view on it, on the House of Representatives plan.
All right. Thanks, Dave. So have you had a chance to look at it?
I have reviewed it. Now, I guess my role at Community Medical Center is more the ambulatory or the physician office side. So I don't review in detail really how the hospital or can't speak to how Community Medical Center feels about this. In my world, I have reviewed it, and there isn't any funding cut to the programs that I manage currently. We all know that there's some funding that could be possibly cut for Medicaid, and we would have to see what that looks like for us in Montana and for these programs in the physician offices. But so far, the Innovation Center has not been listed as one of the programs where the funding would be cut.
You work in a place called the Innovation Center?
So that's a CMS. That's a CMS, I guess, department under the Medicare and Medicaid services, where these alternative payment models start and come from. And their funding, as of right now, is not being discussed. So,
yeah, when we were off mic during the commercial break, I asked you about this, and I want to bring this up. When the Affordable Care Act, Obamacare, whatever you want to call it, was being discussed several years ago, I had a chance to interview some CEOs of some of the smaller hospitals around Missoula, and one of them said that what they were most concerned about was the percentage of payments from Medicare and Medicaid coming to the hospital to cover, covered services, and sometimes they're lower than 35 or 40 or 45% of what the let's say it was a wrist surgery, of what that actually cost. That would be the what they paid the hospital, and that's nowhere near enough to cover the actual cost. So you got to wonder, is that a continuing problem, or has that gotten better with this new system?
So yes, that has been a problem on the physician side as well. What really Medicare, Medicaid, and CMS is trying to do is when they put MACRA, so the Medicare Access and Chip Reauthorization Act, into effect in 2015, that was legislation that passed, they appealed the sustainable growth rate, which would lessen the amount that we get paid by a certain percentage each year, fee for service, and they're replacing it with this quality payment program and alternative payment models. So in the ambulatory physician side, really they're trying to make up for it by paying us for quality. So right now we don't necessarily see a decrease in what we get reimbursed. We see actually a little bit of an increase with these alternative payment models. But of course, over time, we realize that will probably change.
Is that increase, is it just related to the other model, or is it overall? I guess, can you see what I'm saying? Because you said that they're decreasing the amount of payment under the fee-for-service, and they're increasing the amount of payment under the newer method. But if you weren't looking at these two methods and the payment that you're getting from this one government agency, I mean, how does it stack up to the private sector paying you?
Yeah, so not a lot. I guess right now there's 2 commercial insurance companies that are part of this alternative payment model, Comprehensive Primary Care Plus, and that's Blue Cross Blue Shield and Pacific Source. There might be more companies added next year. that makes up a very large percentage when you add it to Medicare and Medicaid. That's a very large percentage of our patient population at Community Physicians Group. So we all know that we have to decrease costs. And so this is really one strategy that the government and commercial insurance companies are using to pay providers, to pay physicians, to lower cost and to increase quality and focus on patient experience and less on the actual office visit. So right now we aren't experiencing a lot less on the office visit because they're giving us time to put all these services in place. But in my opinion, it's really the right thing to do, and it's where we need to go in healthcare.
How is any health organization, whether it's a clinic or a hospital or whatever, how is it judged when it comes to quality care? When each, or quality of care, let's say I get out of the hospital after having kidney surgery or whatever, is there like a survey, or does someone sit down with me and ask all these questions, or maybe I have complaints. I had a nurse who was rude to me, or whatever it might be. The patient experience, does that actually affect how much the hospital is paid?
So there are surveys that go out in alternative payment models. So a lot of patients.
Let's just say my surgery cost $50,000. Okay, and that's the amount that I am billed for my surgery. If I have a poor patient experience, would this fund pay less to the hospital, and then I would be responsible for more? Or how does that work? I'm just confused.
Yeah, so on the physician side, so again, not so much hospital payment.
Right.
But they're starting to look at your patient experience scores on the survey. And that can be used to adjust your performance incentive. So if that's one of the measures that you choose or that CMS chooses to use, then yes, that could impact our payment.
But
Wow.
it sounds to me, Peter, from what she said earlier, and correct me if I'm wrong, April, that the big thing is this checklists that they're going through, that I think you said 23 different points that they go through for each individual patient that comes into the hospital to make sure you've kind of hit these markers.
Okay.
And that kind of details the amount of money that they will receive as a hospital. And basically the difference in viewpoint is they're not just there when you get sick. They're there all the time. So they have an interest in making sure you don't get sick. Where in the current system, how do they make money? Only when you get sick and you're in trouble.
Okay.
So they don't really have an ongoing interest in your health until you screw up, which luckily we're pretty good at.
Exactly. Yes, we're getting paid to keep people healthy, which is what we should do.
Rather than just fix them when they're sick.
Right.
All right, we're going to come right back. If you have questions, give us a call. 721-1290 is our number. Our guest is Apyle Pickering, Director of Population Health and Government Programs. Very interesting information here. If you have a question, give us a call. It's 721-1290. Yeah, we're back. This is Health Talk. 721-1290 is our number. 1-800-568-5309. The last few minutes with Apyle Pickering of Community Medical Center.
Yeah, I guess I was curious. You said that there's these different providers that use this comprehensive Care Plus model. Do the recipients of the health care, the regular citizens, do they know that the insurance companies are paying in these different ways? Do they sign up for a different program, or how does that part work?
So there's some signage in the clinic with some alternative payment models, like different ACOs or accountable care organizations. They get a letter in the mail from Medicare letting them know they're participating. But I would say overall, most probably don't realize the changes.
They don't even know they're
payment.
getting the plus.
Right.
So how can I, as a patient, let's say I'm not on Medicare or Medicaid, I'm just a regular person, how can I be proactive to make sure that I'm getting everything that you want me to receive? How can I, as a patient, do this?
So whether you're Medicare, Medicaid, or a different insurance company altogether, really we're here to help you to make your experience more convenient and patient-centered. So if we reach out to you to sign up to our patient portal so you can get access to your electronic health records online, that would be a great thing to do so you can communicate with us electronically. Or if we're reaching out to you or discussing different quality measures, are you due for your mammogram or cervical cancer screening? Those are all great things that you can help with so that you continue to remain healthy.
Real quick, you said after MACRA that you get paid more on the new model than on the old model, the fee-for-service model.
Mm-hmm.
Do I pay more as a client under the new model as opposed to the old model?
No. Probably overall with some of the new things that we're doing, you would get paid. You would have to pay less actually with some of the things we're putting into place. So we're doing like alternative office visits where we could have an office visit over the telephone with your primary care provider. That's of no charge to the patient right now. So there's some great things we're doing that.
We're rapidly running out of time. We need some contact information, getting hold of your office or community, or how do we do that?
So I'm always available on email at Community Medical Center. So Pickering at communitymed.org, or you can call Community Medical Center
728-4100
and ask for me at any time.
Good deal. April, it's been a pleasure.
Thank you very much for having me.
Very informative. You know your stuff. Good job. All right. That's going to do it for Health Talk. We have an hour of open phones on Talkback coming up in just a moment. Our first Talkback in over a week.
Woohoo!
We'll be right back. Stay with us.